This chart shows the massive disparity in out-of-pocket healthcare payments between developing and developed nations. In low-income countries, patients directly shoulder the vast majority of medical costs. High reliance on cash payments leads directly to catastrophic financial loss during medical emergencies. To understand how to solve this, we have to look at the physical reality of agrarian and emerging economies. Nations like Nepal face specific systemic challenges built into their economic structures. Chronic underfunding generates a fractured three-tiered health system. At the top, an affluent minority purchases private care. In the middle, formal employees rely on protected government insurance. At the massive bottom tier, poor and informal workers rely on cash payments at underfunded public clinics. Social health insurance replaces this unequal pyramid with a unified risk pool. It uses mandatory, earmarked payroll taxes to pool risk between the healthy and the sick, redistributing income from the rich to the poor to pay providers evenly. But legislating social health insurance does not instantly generate universal coverage. Transitioning away from out-of-pocket reliance requires a nation to cross specific, multi-decade economic thresholds. Tracking the evolutionary stages of 5 specific nations, Kenya, Ghana, the Philippines, Colombia, and Thailand, provides a precise blueprint for countries like Nepal to escape the three-tiered trap. We can track these nations across 3 distinct coverage regimes: contributory, subsidized, and voluntary. In Stage 1, design and initiation, countries like Kenya and Ghana hit an immediate structural wall. This chart details the demographic reality. Roughly 50% live in poverty, 40% work in the informal sector, less than 10% have formal employment. The math fails. The tiny formal sector cannot generate enough revenue to cross-subsidize the other 90%. Identifying, tracking, and collecting monthly premiums from millions of off-the-grid farmers and street vendors creates immense logistical friction. Ghana addressed this friction through a specific policy innovation: district mutual health organizations. Rather than enforcing a top-down mandate, the government legally integrated existing, trusted community financing schemes directly into the national structure. In contrast, Kenya's rollout stalled early. Projections showed the fiscal costs of expanding their national hospital insurance fund were mathematically unsustainable. For nations mapping their own systems, like Nepal, these demographic hurdles define the necessary baseline architecture. Bypassing the Stage 1 blockage requires legally absorbing informal community networks. Without that integration, coverage never expands beyond civil servants. In Stage 2, middle-income nations manage to cover 60 to 70% of their populations, but then development stalls. Colombia forced equity through a structural mechanism, the Solidarity and Guarantees Fund. The law mandates a specific percentage of premiums from the formal contributory regime flows downward into a separate pool. This explicit cross-subsidization mathematically forces the wealthy to fund the subsidized regime. The Philippines exposes the critical vulnerability of the middle tier, the voluntary regime built for informal workers. Voluntary health insurance systems face an unavoidable threat: adverse selection. This creates the evasion gap. Healthy workers evade paying premiums because they feel fine. This triggers a death spiral as only sick patients enroll, rapidly draining the fund. The Philippines recorded a 70% evasion rate among small employers, creating a massive missing middle. Relying on voluntary enrollment in the informal sector mathematically bankrupts the system. Surviving the middle-income trap requires mandated cross-subsidization, like Colombia's. Stage 3 evaluates how a nation crosses the final threshold to cover 100% of its citizens. Thailand serves as the benchmark case study for achieving rapid universal coverage in a middle-income environment. This graphic maps Thailand's highly fragmented health systems leading up to the year 2000. 4 disparate schemes ran in parallel for decades, resulting in massive administrative bloat and unequal care. A drastic 2001 political decision collapsed these tracks into a single, universal national pool. Making this possible required a core economic threshold. Thailand had reached approximately $2,000 per capita GDP. Hitting this wealth metric allowed the government to inject massive tax revenues directly into the Social Health Insurance Fund, fully subsidizing the remaining 75%. True universal coverage requires an economic threshold that allows severe political redirection of general tax revenues. It is rarely achieved purely by collecting premiums. Collecting revenue is only half of the system. Social health insurance acts as a mechanism for structural delivery reform. We can contrast the old model of healthcare funding against the new SHI model. In the old supply-side model, the government blindly hands a bulk budget to a public hospital, regardless of how many patients they see or the quality of the care. In the demand-side model, the independent fund holds the national money. It acts as an active, strategic purchaser of health services. Both public and private hospitals are forced to compete for funds, based strictly on patient volume and quality metrics. Controlling national costs requires moving away from inflationary fee-for-service billing. Purchasers use capitation. The provider receives a fixed flat rate per assigned person. This forces hospitals to prioritize cheap preventative care over expensive reactive treatments. Without transitioning from a passive payer to a strategic purchaser, the system merely funnels more money into an inefficient delivery network. This chart plots the progress timeline tracking the trajectory of all 5 case study nations. Thailand's steep vertical ascent rapidly crosses the 100% universality mark after its structural consolidation. Compare that to the projected slow, multi-decade crawl of agrarian economies like Ghana and Kenya. For students and policymakers analyzing economies like Nepal, the data proves that legislating social health insurance is an evolutionary timeline. Climbing the graph requires 3 mandatory operational steps: integrate informal networks, mandate cross-subsidization, and enforce demand-side purchasing. Universal social health insurance provides the architectural tool for national equity, but it demands decades of rigorous, data-driven political commitment to build.